Hello, and welcome to the Better Man Clinics, the podcast where we talk to actual experts to address the questions that men want answered, but are either too embarrassed to ask or simply don't know who to ask. Before we get started, I do want to caution that the conversations on this podcast are for informational purposes only. They don't represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope that the podcast empowers men with the knowledge and confidence to address these issues with their healthcare providers. As with any medical or wellness issues, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. With that being said, in today's episode, we discuss male pelvic pain, a problem that few men want to talk about, but one that many men suffer from. In men, pelvic pain can present as pain in the penis, the testicles, the groin, and the perineum, which is that space between the testicles and the anus. Pelvic pain can be a very bothersome problem and even debilitating for some men. It can keep men from participating in activities that they enjoy and can frankly destroy their sex lives. The problem is made still worse by the fact that most men don't feel comfortable talking about it and frankly don't know who to talk about it with. Fortunately, to help us better understand the causes and possible treatment options for male pelvic pain, joining us today is an expert in male pelvic pain. Elizabeth Akincilar received her Master's of Physical Therapy from the University of Miami Medical School. She is the co-founder and president of the Pelvic Health and Rehabilitation Center, with 9 locations in California and New England. She is active in the professional community, lecturing and teaching nationally and internationally. She is the co-author of the book Pelvic Pain Explained and contributes to medical texts and other professional literature. And now, I bring you our conversation with Elizabeth Akincilar about male pelvic pain. Hello, and welcome to Better Man Clinics. Today, we're going to be talking about pelvic pain, a problem that a lot of men face, but many are either too embarrassed to talk about or they don't know who to talk about it with. And the bigger problem about pelvic pain is that most doctors don't know how to deal with it either. And that leads to a big, big problem. Luckily today, we are very happy to have with us as a guest on our program, Elizabeth Akincilar, a licensed and certified physical therapist and a specialist in male pelvic pain. Elizabeth, welcome to the program.
Thank you so much. Thanks for having me.
Absolutely. I'm very excited to dive in because, as I mentioned to you before we came on, I, as a urologist and many other urologists, really it's a pelvic pain is a challenging problem. There are some common issues with pelvic pain that we treat, that we feel very comfortable treating, but once that kind of part seems to not work, then it becomes a conundrum. And this is kind of where I think the physical therapy, the rehab side of management pelvic pain is vastly underappreciated. So we're very excited to hear from you, your thoughts. And I think first, I'd love to hear about you yourself, how you decided to go in this field and specifically have a focus on male pelvic pain.
Yeah, so I've been in this field about 20 years. When I first started, I was living in San Francisco and I had been working as an orthopedic physical therapist, and it just really wasn't for me. So, back then I searched on Craigslist for jobs, as we used to do 20 years ago. And I came upon this job ad at a urologist office looking for a pelvic floor physical therapist to treat pelvic pain. And I thought, I didn't even know what that meant. I mean, pelvic pain was not even mentioned in any of my grad school education, but it interested me. And so I applied for the position. I spent a day with that urologist and his physical therapist, who is the other physical therapist that was there, who is now my business partner. Oh. And I spent a day just seeing patients with them. And I thought it was so interesting. I couldn't believe that I had never heard of this before. And the stories that I heard from both men and women were just so striking. The amount of functional disability, the effect on their quality of life was so dramatic. And to hear them tell me how much these providers were helping them get their life back just really struck me. And so I was immediately interested. I started working there, really kind of fell in love with the work. And then so a few years after that, my business partner and I started Pelvic Health and Rehabilitation Center in San Francisco, where we focus on treating men and women with pelvic floor disorders. And so we've been doing that for the last 15 years. And, you know, as far as a specialty in male pelvic pain, it wasn't really an intention. You know, I really focus on complex pelvic pain, particularly neuropathic pelvic pain. And I have just seen a lot of men over the years. And so I've done a little bit more education around male pelvic pain for the community, for providers. And so it's just kind of turned out that way.
Well, that's wonderful you're doing that, because it is, like, as I mentioned, it's just so needed. I for one am excited to get some tips for sure in terms of kind of how to approach it. I guess
Yeah.
first question, just to kind of frame it, do you have an understanding of how common pelvic pain is really amongst men?
Yeah, amongst men, what's published is somewhere between 8 and 12%. I really think that is so much higher, to be honest with you, because if you look at the rates of chronic prostatitis, you know, whether it's chronic non-bacterial prostatitis or actually bacterial prostatitis, I mean, that number is very high, right? I mean, I think, obviously you would know that better than I, but I think a lot of those men are incorrectly diagnosed with bacterial prostatitis, and they actually have chronic pelvic pain or non-bacterial prostatitis. So I think that number is a lot higher. I mean, in women, it's, you know, 20 to 25% of women. So I would imagine it's a little closer to 15 to 20%, but we don't know.
Excuse me. Yeah, I mean, that's very true. And I think that, you know, I'm sure we'll talk about it later with prostatitis, is, you know, just the inflammation of the prostate. And I think that it's often a knee-jerk reaction to call male pelvic pain prostatitis, where, as we'll learn, there's a lot more to it. Before we dive into causes, though, you know, pelvic pain is a pretty generic term. It can mean a lot of things to different people. For men, what are the common symptoms that men come to you with under the umbrella of pelvic pain?
Yeah, it's a good question. So I think some of the most common symptoms are perineal pain, sitting pain, feeling like they're sitting on a golf ball. Penile pain is a pretty common thing, or tip of penis pain, even more specific. And then post-ejaculatory pain is probably, as far as sexual dysfunction goes, probably the most common symptom that I find in men. And that's, you know, under that umbrella, very often men will also have urinary dysfunction and bowel dysfunction, things like constipation or incomplete bladder emptying or frequency, urgency. Often those symptoms go hand in hand.
Got it. And that makes sense, because, you know, the perineum you mentioned, that's the space between, kind of like, for those guys listening out there, it's a space between the testicles and the rectum, colloquially known as the taint, I think it was called. So that area there, that it's also kind of the location of the prostate, which makes it not surprising that, you know, prostatitis comes up so often as, hey, you just have prostatitis, because it's right there. What else could it be, right? Well, I guess we'll learn what else could be. And to that extent, you had mentioned pain with ejaculation, urinary symptoms. Why is pelvic pain wrapped up with sexual issues as well as urinary issues so often?
Well, the pelvic floor has kind of two components as we look at the more superficial pelvic floor muscles, also known as the urogenital diaphragm, and then the deeper pelvic floor muscles, which are known collectively as the levator ani muscles. So the urogenital diaphragm are in part responsible for urinary functioning, particularly when we want to not leak. When we laugh, sneeze, or cough, those muscles have to contract in order to prevent that leaking. In addition, those muscles are intimately involved in sexual functioning. So they have to be able to contract and relax in order to get an erection, maintain an erection, and also they have a role in ejaculation. So when those muscles are dysfunctional, and what I mean dysfunctional is they're usually too tight. All right. Rather than weak, they're actually too tight. So during sexual functioning in particular, when those muscles rapidly contract and relax during ejaculation to push the ejaculate out, those muscles, if they're too tight to begin with, can just tighten and tighten and tighten, and you don't get that relaxation afterwards. Therefore, after ejaculation, it's almost like you have a cramp in those muscles and it produces pain post-ejaculation. So what we try to do is to relax those muscles so when you enter a sexual situation, those muscles are at a normal resting tone or not so tight so they don't tighten up too much during ejaculation.
Got it. And so would you say it's primarily those muscles that are responsible for all the pelvic pain syndromes that we hear about?
Well, yeah, not necessarily. So the muscles are one component. There's also the fascia that is around our muscles or superficial to the muscles that can play a part in pelvic pain, in that when there is dysfunction in underlying muscle or nervous structures or even viscera or organs, the superficial tissue responds in that it becomes less mobile. And when that tissue, and the tissue I'm talking about specifically is called connective tissue. It's the tissue between the skin and the muscle. Mm-hmm. When that tissue becomes not mobile or hypomobile, it doesn't allow good blood flow in the tissue, which can cause a hypersensitivity in that tissue. If you think about, if you put a rubber band around the tip of your finger and the tip of your finger becomes kind of hypersensitive as the blood is cut off, that is somewhat what happens more globally in that situation. So that's another contributor to pain. And then nervous or neuropathic pathology can absolutely contribute to male pelvic pain. And so the nerves that we really consider are, of course, the pudendal nerve, which supplies the genitals, perineum, anus, rectum, part of the bladder. The other nerves that we consider are the ilioinguinal nerve, genitofemoral nerve, sometimes iliohypogastric, posterior femoral cutaneous. So a number of nerves can also play into male pelvic pain.
Got it. So it's that combination of the nerves and the muscles, the structures all interacting. And is it that nerve transmission that, again, if somebody comes in with pain at the tip of their penis and they think something's wrong inside their penis, could it just be a nerve pain transmitted from somewhere else?
Indeed. So the pudendal nerve terminates, or one of the branches of the pudendal nerve, the penile branch or the dorsal branch, terminates at the tip of the penis. So yes, that's absolutely one of the more common causes of penile pain, particularly if the description of pain is burning, searing, stabbing, electrical type pain. Those are symptoms that are more consistent with neuropathic or nerve-related pain versus pain that's achy or sore or feels like a bruise. That tends to be more muscular in nature.
And does that type of pain also translate into the testicles as well, or not as much?
So it depends. So, when men talk about pain in their scrotum or testicles, I really want them to differentiate between the two because, of course, they have different innervation or different nerves supply the testicles versus the scrotum. But yes, scrotal or testicular pain could be due to a nerve that's irritated. Testicular pain is usually more neuropathic in nature or something more visceral that I would refer back to my urology colleagues. Scrotal pain can be referred by muscular structures, though. So that is something that we see not as frequently as penile pain, but we definitely see.
Yeah, and this is the point specifically about penile pain is an important one. Why? Because this is where a lot of frustration comes in. What do I mean by that? A man comes in and says, the tip of my penis hurts. And the doctor examines the penis, says, there's absolutely nothing wrong with your penis. We'll send you to a urologist. And the urologist looks at the penis and says, there's nothing wrong with your penis, but you know what? Maybe there's something wrong on the inside of your penis. So we'll we'll put a camera in, we'll check it out. We'll make sure. I mean, they're doing their due diligence. And you know what?
Sure.
Sometimes there is something wrong and you find it, but a lot of times there isn't. And that's where that frustration with patients come in, with men that comes in, where they say, I don't see anything wrong. My doctor thinks, when you start thinking, does he think I'm crazy? Does my wife or my partner think I'm crazy? Like, I'm feeling this, but you're looking at my penis, there's nothing wrong with it, right? And that understanding that pain is actually being generated somewhere else and being transmitted to the penis, that's kind of where that disconnect occurs. And it's just so important that you point that out, because, a lot of guys unfairly are, kind of questioning themselves, like, am I really feeling this, or what's going on, basically.
Yeah.
So,
yeah. I think that's a hard concept for the average person to understand, that there is a possibility that pain can be referred from another structure. That's absolutely something that I've seen many, many times with men. They're just convinced that there must be something wrong with the organ itself,
right.
versus having pain referred from another structure. Yeah.
Right. And on the flip side, some guys get upset when even if they're told correctly that the pain is coming somewhere else, but they're like, no, it's my penis. That's what's bothering me. Right. So it's a lot, and that's kind of what we're hoping to achieve here, is a little bit of education as well. So guys feel comfortable with that concept that, you know what, it may hurt in your penis, it may hurt in your scrotum, but it may not be coming from there. And of course, here's the public service announcement: always go to the doctor, always get checked out. Have a urologist take a look, have them make sure nothing is going on at the organ structure. But if they don't find anything, that's where this conversation comes in very important.
Absolutely. Absolutely.
So,
I mean, treating pelvic pain has to be a comprehensive and interdisciplinary treatment plan, right? That involves physicians, whether it's a urologist or a pain management physician, physical therapist, sometimes mental health specialist, but it has to be really an interdisciplinary approach to be successful.
Exactly. So one thing we focus on this program is prevention, right? So to the extent that we can, let's talk about, get a better understanding. What is there anything that men are doing, not casting blame, but is there anything that men are doing that might bring about this pain? Any type of activities maybe they should think about either avoiding or cutting down that might be contributing?
Yeah. Well, now we're going to get on my soapbox a little bit here. So I really think a common denominator, and this spans all people that struggle with pelvic pain, one of the common denominators is constipation. We do a very bad job in Western countries, and I think beyond, of talking about how to actually poop, right? Many people, I mean, no one talks about it. I mean, when's the last time your, primary care provider asked you, like, well, how exactly do you poop every day? Most people have no idea what the right way to do is. I mean, I think the squatty potty that has been made very, kind of famous, well, at least in my world, I think that has brought some awareness.
I am familiar with it from Shark Tank. Yeah. Absolutely.
Right. I think that has brought some awareness, but prior to that, no one really talked about it. So I think people's dysfunctional ways of evacuating stool, particularly straining to get stool out, is one of the big causes of pelvic floor dysfunction. Because when we strain, even though we think we're using our muscles to push that stool out, what we're actually doing is tightening those muscles and using our intra-abdominal pressure to push through that tightening. So if we do that on a day-to-day basis, those muscles just essentially become tight, and they stay tight because that's now their more comfortable state. So that's one.
Wait, can I interrupt you for 1 second? Can I interrupt you? Let's go back to pooping real quick. So just without seeing a practitioner, how would you know if it's your I mean, people don't, like you said, people don't think about this, right? Like, how do you know if you're straining too much, or if you're truly, a lot of people don't even know they're constipated before somebody tells them.
Absolutely. People would say, well, no, I poop every day, I'm not constipated, but it's how you poop. That's what I'm interested in. So a couple of things to know that I always ask patients if they say, no, I'm not constipated. Oh, have you ever had hemorrhoids? Yes. Okay, that's a sign that you're likely straining. Have you had a history of fissures or little tears in the anus that cause a little bit of bright red blood when you clean yourself after? If you have a history of that, that likely means that you're straining to have a bowel movement. If your stool is, pellets or corn cob-like, I always say the goal is smooth like a snake, right? That's what we want. So if it's anything harder than that, that lets us know that that stool is likely sitting in you too long and you're not going frequently enough. If you're red-faced when you have to have a bowel movement, those types of things. So sometimes I'll ask those questions, which lead us to the conclusion that indeed you are straining to have a bowel movement. Often I'll say, when you do strain, Do you really have to bear down? And sometimes people don't know what that means. So I'll often, mimic a Valsalva or really
Right.
bearing down, and people are like, oh, well, yeah, but it still comes out. So just educating people on what that means. And starting with that.
Perfect. Perfect. Sorry, please go on. You were going to talk. I apologize. I just wanted to dive down because people, you can't stress that enough, that people don't always understand what constipation is.
Yeah,
But
yeah.
what other elements were you going to talk about?
So yeah, particularly with men, some things that we commonly see on the exercise. There's a few different things. So with exercise, really heavy squats. So when we squat, especially like a deep squat, like a catcher's squat, the pudendal nerve glides over a small bone in our pelvis called the ischial spine. And if you do that repetitively with a lot of weight, that nerve can become irritated and then cause pelvic pain. So we do see that sometimes with men who do lots of really heavy squatting in the gym. Cyclists, now, I mean, we don't really know, we have some hypotheses, but why some people can spend 6 hours every weekend on a saddle cycling and they're just fine. Maybe they have a little bit of, irritation or numbness, which is not great, but it resolves. And then other people will really develop pelvic pain. And again, that's often because the structures, when you're sitting on that small, hard seat, the structures of the pelvic floor, as well as the pudendal nerve, are being compressed. And when structures like that are compressed, they become ischemic, or they don't get enough oxygen because the blood flow is somewhat compromised, and that can produce pain and dysfunction. Now, some people don't develop that, and one of the hypotheses is that some people's anatomy may be slightly different, where that nerve doesn't have as much mobility because of a little variation in anatomy, and that difference in anatomy compromises it enough that someone can develop pelvic pain. So that's kind of on the exercise bit. Other things are just more sitting. This last year and a half is a perfect example where people have been more sedentary, staying at home because of COVID, working from home, sitting, and just that increase in sitting, like cycling, can compress those structures, compromise them, and produce pain. The other thing that we see with men is around sexual functioning. So some men will either masturbate too often or too aggressively, literally causing too much tension on the penis or the penile shaft. And that repetitively or over a long period of time can cause irritation to that pudendal nerve, particularly the penile branch, with that aggressive lengthening, and can develop pelvic pain. Or any techniques to try to lengthen the penis, like is known as jelqing, that can also cause an injury or irritation to the penile branch of the pudendal nerve.
Got it. And so you outlined some pretty concrete examples of activities. Is the understanding then that, like, let's say if I bicycle ride and I'm getting chronic pelvic pain, if I stop, will it just go away?
Good question. So the answer is hopefully, but I think the thing that makes the most sense is, yes, you stop the activity, you see what changes. If the symptoms resolve, great, maybe slowly get back on your bike and see if the symptoms resolve. But if they don't, if the symptoms persist, then I think you always want to check with your physician to make sure there's nothing wrong that could be identified by a urologist. But if all of those diagnostic tests come back negative, then it's time to seek out an evaluation with a pelvic floor physical therapist.
Got it. And do you know, a lot of guys, they get very discouraged because they're told that bike riding is causing it. Maybe they love bike riding. Is there a path that men can take precautions or therapy where they can potentially resume those favorite activities? That, I mean, not the constipation is a favorite activity, mind you, but the ones that people actually enjoy, that like bike riding, like maybe they love to do squats for whatever reason. Is there a path to get them back to doing what they really like to do?
Absolutely, absolutely. And I think that's an important point to make. Even if we take away activities for a temporary period of time, it doesn't mean if your goal is to get back on the bike or get back in the gym and doing squats, then that's my goal for you. And
Mm-hmm.
that's what we will work towards. And there are often things that we can do to set you up for success. So it's often not just the compression on the bike or on the seat that's causing that. There are other things that you may be doing in your daily life that are also contributing. So things like if you sit, at a desk all day, creating a sit-stand workstation so you're not sitting all day may help. If you are constipated, obviously improving your bowel functioning, incorporating exercises to actually relax your pelvic floor muscles, maybe before you get on the bike and after you get on the bike to try to combat some of that tightening that's happening. If there's other things that you're doing in life that are compromising that pudendal nerve, identifying those behaviors or activities and modifying them. And it happens over time. If you have severe pelvic pain and can't sit at all because of the pelvic pain, and you want to get back on your bike, that's not going to happen in 6 weeks' time, but it indeed could happen if that's the goal, then that's what we work towards.
Got it. Got it. And, we talked about some pain and stuff, but like, what do you tell people in terms of red flags, like pelvic pain and is a bad sign?
Yeah, absolutely. So numbness, true numbness, not altered sensation, not like, oh, it feels like pins and needles, but actually when we take something sharp and touch, the genitals or the perineum and you can't feel that, that is a red flag, right? Also motor loss. So all of a sudden starting to leak urine or leak stool or inability to get an erection at all when that is a new symptom. So motor loss and true loss of sensation are red flags to me.
And just on a high level, just so people understand, what is that a sign of?
Could be a sign that the pudendal nerve is being compressed to the point where it's not conducting activity at all, and it could be entrapped. And that's something that I would send to my colleagues who specifically treat pudendal nerve entrapment.
Got it. Well, that's very good to know. Assuming we don't have those red flags and we have, I'm going to call it run-of-the-mill pelvic pain. And I'm a guy, and as you know, guys really don't like to go to the doctor. What can we try at home? If anything, what resources are available to us before we talk to the professionals to give it a try?
Yeah, so I think that's a great question. And when I talk to folks from, across the country or the world, that's absolutely what we talk about. So I think easy things to do are start a mindfulness practice, right? Something that encourages you to focus on decreasing, kind of turning the volume down, as I say it, on your central nervous system, focusing on your breathing. When we really focus on our breathing, particularly if we expand our diaphragm or really expand our rib cage, our pelvic floor relaxes automatically. So practicing that, we tend to breathe from up here, not from our belly. So practicing that with a mindfulness practice can help relax the pelvic floor and sometimes really help a lot, just that alone, to reduce symptoms. Not straining to have a bowel movement, again, my soapbox, and just educating them using the squatty potty, not bearing down when you have a bowel movement, improving your diet, increasing your activity, all of those things. As far as self-treatment goes, with particular kind of treating muscles or tissue, that's a little bit harder to recommend without having some idea of what's going on, right? So those are things that we really need to assess the man and identify those things. And then we can give them ideas on how to self-treat at home, whether that's with a tennis ball or something called a Theracane or a foam roller. There's a million tools out there that you can use, but we can help kind of identify which would be best for them to use. There's a couple of positions that are facilitatory to relax the pelvic floor that I'll often suggest. So for those of you who are familiar with yoga positions, there's a position called Happy Baby, which is essentially on your back and you bring your knees kind of towards you with your legs externally rotated. And in that position, with focusing on your breathing, that helps to facilitate pelvic floor relaxation. Child's pose is another position that can help to facilitate pelvic floor relaxation. There are a couple of tools out there that can get people started.
Perfect. I know child's pose. That one I know. And I'm not a big yoga person, but at least I've heard of that one. That's for sure.
Yeah.
So with a couple of things, going back to tools, like again, you'd mentioned Theracane or foam roll, all that stuff is out there. You don't need a prescription. But if I caught you correctly, do you need somebody to kind of point you in the right direction? Because you see those things, and I saw them online, and one of them looks like a weapon of mass destruction. But I'm sure if used the correct way, it could be very valuable. But I just worry about guys just trying to poke themselves and roll and do that. Potentially, they could do more harm than good, I would imagine, right?
Right. Yeah, you really do need someone to point you in the right direction, because pain is not always a good thing. It's no pain, no gain. It's really not true. You really need to know where the dysfunction lies or where the muscle impairments are, and then how to target them. But just using a foam roller and rolling all over your legs and your butt and everything, be like, oh, that really hurts, I'm going to really, grind on that, doesn't necessarily mean that's a good thing to do. So I caution people from going online and looking at some, foam rolling routine that someone put on, like, oh, here's a series of exercises for pelvic pain, and just going through those series of exercises is not a great idea, particularly if there's any neuropathic involvement. So nerves are very, they're very stubborn, and they're somewhat vengeful structures, I think. Once you irritate them, it takes a while for that irritation to go down. So some of these stretches and exercises that are online could really compromise a nerve. Even it's already irritated to begin with, you could just further irritate it. So particularly if you have nerve symptoms, burning, shooting, stabbing, lightning bolt pain, you really want to be particular about what exercises you do without the kind of guidance of a physical therapist.
Yeah, but that's perfect. I think that's fantastic advice. And in that same vein, social media has become, dominant. And sometimes it can be very helpful. There's a lot of great support groups out there. If you go on Facebook, you name the platform, there's a million of them. Chronic pain is definitely in that realm. And there's a ton of support groups out there. What are your stance about diving in there again, and not diving in there, period, but diving in there without a shepherd or a Sherpa to kind of, guide your path?
Yeah. So this is a tough one, right? I think as providers, many of us have gotten into the social media world because we realize people want the information. They're hungry to be educated, and particularly with pelvic pain, they're not necessarily getting that education from their primary care provider. And that's not to dig on primary care providers. Pelvic pain is a very specific, kind of not well known and understood part of medicine. So people are online, they're Googling everything, right? So with knowing that, we have, as many providers have entered that, the social media world to try to educate people, at least give them the information, and get good information too, right? Not just anecdotal information, but actually data-driven information that can hopefully get them on the right path. So I think I'm getting away from your question, because social media is always one of these kind of conundrums. You don't want to diagnose people online, obviously, and you just want to give people enough information to hopefully seek out a provider who can get you the rest of the way. And that's really what we're trying to do, as well as try to lessen some of the anxiety around some of these pain issues, because having pain in your pelvis is quite anxiety provoking. I mean, everyone will talk about their knee pain and their shoulder pain and their back pain, but you're usually not sitting at dinner talking about your penile pain, right? So I think it's a way to educate and just bring awareness to it, and hopefully it leads to getting to the right provider.
Yeah, I mean, it's I agree with you. It's definitely a challenge. Like I jumped on a few of these pain support groups just to check it out, and I think it's a double. It's also extremely beneficial in the sense that you're going on there and you see you're not alone. You
Yes.
see there are people who can not only empathize, but sympathize with the pain you're having. They're validating that pain. Some of them can even share their stories of their journey and potentially send you to the right person, or at least refer you. But what always worries me is then mixed with that is you have that contingent of charlatans and snake oil salesmen, and oh, but you know what, I was told that if you hang upside down by your feet 16 times and say something, then you'll be cured. And that it's that, desperation that leads people to say, well, I'll just try anything. That's what worries me about the social media part.
Absolutely. I couldn't agree with you more. When patients tell me that they're on various support groups, whether it's Facebook or whatever it is, I always caution them. I always encourage them, if you want information about whatever it is, come to me. I will find that information for you, right? I will find, really evidence-based medicine or evidence-based information as much as I can. Because, in these groups, like you said, there are people that will say, oh, I tried, I have similar symptoms. I tried this and that worked. Well, as we know, everybody, I know it's kind of trite, but everyone is so unique, and no two patients are the same, and no two histories are the same, et cetera. So you can't compare yourself to someone else online. And the other thing about these online groups is the folks that tend to really frequent some of these support groups are often folks who are still struggling and still looking for solutions. And so I think it paints a picture that no one gets better, that no one improves, because many patients who do improve and return to their previous lives of, having sex 3 times a week and bike riding when they want, they're not on those groups anymore. They're getting on with their lives, So when I have patients that have success, I'm like, please, if you were on one of those groups before, go post your success stories so people know that there is another side to this. Not everybody, this is not, you're not damned to be in pain for the rest of your life. So that's one of my real struggles with some of those groups. But I'm grateful that they're there, because it does allow people know they're not alone. They're not it's not they're the only person or some freak or something like that. So I do appreciate it for that.
So now a tough question, because there's kind of like choose your own adventure here. So, because there's insurances and all this other stuff in place. What's the usual path for somebody, or maybe not usual, what's the optimal path for a man who develops pelvic pain? We've tried the stuff at home, nothing's really working, I need help. Yep. Who do they see first? Who do they see next? How do they potentially eventually get to like a therapist like yourself that might get to, what's the usual path?
Yeah. So I think with men, they usually go to a urologist first to make sure, all the plumbing is okay. Right. And assuming everything comes back unremarkable, everything's normal. And I think the next step is to see if pelvic floor physical therapist gets the assessment, see what the physical therapist finds, and then you go from there. And then, maybe we have these conversations with patients all the time. If there is a strong neuropathic component, I want them to see a pain specialist to talk about, different medications that may help them be more functional, less pain, help facilitate this process. If there's a strong anxiety component, I may refer them to some sort of mental health specialist to try to, control that component of it. So once we kind of see ourselves as physical therapists, at least in this world, kind of like the captain of the ship, like, come see me, we're going to assess everything, and then we'll get you to other people that will help in this process. Because we see them the most frequently, usually, most physicians will see them maybe, if it's ongoing, maybe on a monthly basis, but we see people on a weekly basis. So we really get to see how their symptoms are changing or progressing, really get to know the patient and modifying, different behaviors and activities in their life. So yeah, I think once they're given the green light that everything, on a, organ base is fine, then the next step is to see a physical therapist.
That's a great point because a lot of times the pathway is they go to primary care urology and then they get referred to a pain specialist who might help with certain elements of it, but not overall. It sounds like
Right.
kind of the way you're describing it is the physical therapist who specializes in pelvic pain is kind of like the primary care physician of pelvic pain because they take a holistic view, they're comprehensive, and then they know if you need a subspecialty referral, they can do that for you. Now that's a great way to think about it. Now, as I mentioned a few times, guys are very reluctant to see anybody about anything, and they're usually dragged in kicking and screaming. And part of that is expectation. What should I expect?
Mhm.
So if I'm seeing you for the first time and whether I came directly or I was referred, what do I expect? What are you going to do to me or talk to me about, or what should I expect in
Mhm.
that first visit?
Yeah. So in the first visit, of course, I want to know your whole history, right? I want to know how this started, when this started, what activities you do, what other health issues you have. I want to know everything about your urinary, bowel, and sexual functioning. Um, so once I get that whole history and really have a good understanding of how this all happened, and also what you've maybe tried in the past, if you've tried other treatments or medications and what's worked, what hasn't worked. And then I do a physical assessment. And so that starts with an external exam. So I'm palpating or examining the tissues kind of from the belly button to the knees, front and back. And so I'm examining the soft tissue below the skin, then into the muscular tissue, and I'm looking for restrictions in mobility. I'm looking for restrictions in muscle mobility, or what we call myofascial trigger points, which are points within muscles that are taut, that don't move well, that can cause pain. We do that exam. And then I also do an internal exam, which is a one finger exam through the anus, and we palpate the pelvic floor musculature. And again, we're looking for muscles that are tender to touch, muscles that don't move well or too tight. We also do nerve palpation of the pudendal nerve to see if there is any nerve sensitivity when we touch that nerve. There shouldn't be severe sensitivity. And if it recreates some symptoms, then those are all significant findings and will help us determine what the best treatment path is.
Got it. Got it. And so let's say they came to you before they saw anybody else. They just came to
Mm-hmm.
you directly. Are
Mm-hmm.
there other medical conditions that you're potentially at least evaluating for or trying to rule out, aside from the actual muscle and nerve problems that you're going to be treating? Are there other
Yeah.
medical conditions that you're thinking about or potentially trying to rule out or on top of your mind?
Sure. I mean, if they really have symptoms of like a prostatitis, urinary dysfunction, perineal pain, or things like that, and they haven't seen a urologist, I'm absolutely going to recommend that they go see a urologist. Make sure that we rule out infection, and not just a prostate infection, but rule out STIs, rule out things like a urinary tract infection, just to make sure that we've ruled out all the easy stuff, so to speak, right? I absolutely. If there's something else, if I'm suspecting something more neurological, if they have real motor dysfunction or motor loss, I may, utilize my neuro colleagues to make sure we're not dealing with something more serious. So absolutely, I always want that collaboration with a medical doctor, whether that's a urologist or a neurologist or gynecologist, because there are some gynecologists that treat male pelvic pain. I absolutely
Mhm.
want them on board. I
Got it.
absolutely want them on board.
It's
Yeah.
it's a team effort for sure.
Yeah.
Now, okay, so I've come to see you, you've done a full exam. What kind of treatment options could you potentially offer me?
Yeah. So we do manual treatment in the office. So that's hands-on treatment to normalize the soft tissue, muscle restrictions or a lack of mobility, also to regain normal neuromobility. We give our patients things to do at home to facilitate that treatment process. Whether various exercises, we suggest things like mindfulness, a mindfulness practice, or incorporating that. We talk a lot about behavior modification. I mentioned before incorporating a sit-stand desk, so you can sit, or you can have the option to stand at your desk, so you're not sitting for 8 to 10 hours a day. There are various cushions that we recommend to provide some relief to some of those structures. Some of them have kind of a donut-like structure to them. There are a bunch of different cushions out there. Some are just more gel-like that help distribute your weight a little bit more evenly on the cushion. We want to talk about your exercise routine and see if we need to make modifications. So say you're someone who goes to the gym and you really like to do deep squats, we may modify them or take them out of your exercise routine for a bit until we can really get the pain under control and then reincorporate them. So it's really, the hands-on treatment, your home program, and then modifying your behavior and activities, that combination.
Okay, putting on my guy hat, everything there sounds great. You mentioned the hands-on treatment though. So
Yeah.
What is that? Is that like a massage? Is that like stretching? What is actually the hands-on treatment?
Yeah, so there are different techniques, different manual techniques that we utilize that will manipulate the superficial or connective tissue as well as muscular tissue. So there's a bunch of different techniques that we use, but it's my hands on you to try to normalize these restrictions that we find in the soft tissue and in the muscle. So we do that externally as well as internally.
Does it hurt?
And internally is with one finger. Does it hurt? If the tissue is dysfunctional, yes, it can be uncomfortable. The good thing is it changes fairly quickly. So once we start to treat those muscular impairments or muscular dysfunction, if we're also changing the behavior that's contributing to whatever caused that in the first place, then it starts to resolve fairly quickly. And I think you were asking this before, and I didn't quite answer. When should you expect a change in symptoms? I tend to tell my patients 4 to 6 treatments, you will see some change. Now, it's not like a light switch that all of a sudden your symptoms are all gone. It's more like a dimmer, right? If your pain was, say, a 6 out of 10 when you walked into the office, within 4 to 6 treatments, maybe it's more like a 4 or 5, right, out of 10. So it's a real gradual change. Or maybe if you were getting up 6 times at night to go to the bathroom, maybe it's down to 4, something like that.
With more and more treatment, do those numbers look better and better, or you're just reaching kind of like a steady state somewhere between 0 and where you were?
That's a good question. So I think the point is to return the person to their desired activities, with as least discomfort as possible. I think it really depends on chronicity of the pain. If you have someone that has been had chronic pain for 15, 20 years, to say that you're going to have 0 pain may not be a realistic goal, right?
Sure.
But, so you maybe have a functional level of discomfort, so meaning like, okay, I know I can get on my bike and I can ride 10 miles and maybe I have, a 2 or 3 out of 10 pain, but in a day or so it resolves. And then I can get back on my bike and do the same thing. That might be very acceptable to some people. For other people, it's not acceptable. So it's really the person's particular goals, and then that's what we work towards.
So I was going to ask you that. So like at the beginning, are you establishing those goals then? And like saying it's not like, oh, well, let's try and see what happens. It's like, you know what, my goal is to go bike riding again. Get me there. Is that how you approach it?
Yes. I mean, that's absolutely on day one. Those are questions that we ask. What are your goals? And if the goals are to get back on my bike, to be able to have, engage in sexual activity without pain, to only get up once at night to urinate, then that's our goals. And then we set goals over a number of weeks. Usually within 4 to 6 weeks, we have a set of goals. And then 8 to 12 weeks, another set of goals. About every 8 to 10 weeks, we reassess and see, have we met those goals, or are we making progress towards those goals? And then we modify them, accordingly. Sometimes people make progress very, very quickly, faster than we think. And other times it takes a little bit longer because there's so many components. We're so dynamic. Our lives are so dynamic that there's a lot of things that are contributing and affecting the speed of progress or lack thereof.
I think having those benchmarks is so important when you have a problem like pain, because pain is not like cancer, that it's there or it's not, or a heart attack where it's there or it's not. And I think that unless people have goals to achieve it, they become very discouraged again, right? Because you have to say, did I reach that? And realize that this is kind of in steps. You're not making enormous leaps right away. I
Yeah.
think that's so critical. I think that's such a great approach that you have to that. How much
Yeah.
does it, how long does a typical treatment take?
So treatments are an hour in length.
Hmm. Hmm.
Usually we see folks once a week. I usually tell, it's very hard to say on day one how long I'm going to see you or need to see you. Usually I need to see somebody for a few appointments to get an idea how they're responding to the treatment. How committed are they to the recommendations that I'm making. And once I have that, and that usually happens in 4 treatments or so, I can usually make a fairly good prediction. All that said, I usually tell folks count on knowing me at least 3 months. Sometimes
Hmm.
it's less, but sometimes it's more. And if you come in with 6 months of pain, 3 months may be sufficient. If you come in with 5 years of pain, it's likely not going to be.
And the reason why it's finite is, I'm assuming, because you're not only doing the manual manipulation is part of it, but at the
Mhm.
same time you're teaching them avoidance, manage things at home, the meditation, all of that kind of stuff is, while you're doing the hands-on stuff, they're doing everything to support it. And so like once you get it to a good place, they can maintain it and keep it from coming back.
Exactly.
Because that's another
Exactly.
thing that guys often lead to a lot of despair, is that, well, pain is always considered as a chronic problem. Like you can treat it, you get a pain in your, you get a massage, you feel better, but it's going to come back tomorrow. But it sounds like you're providing them longer term solutions that they can execute themselves, so they don't need necessarily for you to be their best friend for the rest of their lives, basically.
Absolutely. Absolutely. We want to foster independence.
Hmm.
We want to, educate them and teach them how they can manage maybe mild symptoms or prevent them from escalating. I always tell my patients, but it's funny, we rarely discharge people. It's like, okay, you're doing really good. You call me if you need me, type of thing. I'm here if something happens. I usually tell people, if you have a recurrence of your symptoms, if you've gotten off of your routine of not taking care of yourself, get back on the routine for a few weeks, see if you can get the symptoms to reduce. And often they do. People just need to refocus. But if not, come in, and sometimes you just need a few tune-up, appointments, and it gets you back on the straight and narrow. So yeah, it's about creating independence. It's the same thing with any other orthopedic injury, whether it's your knee or your back. I mean, these are things that sometimes flare up, but okay, I got to get back, and I got to, go back to my stretching or my strengthening or whatever it is. The pelvis is really no different. It's just that we don't talk about this as much.
It makes a lot of sense. And just for
Yeah.
the sake of completeness, are there any significant risks to especially the manual treatments?
No.
Nothing
No, I
like
mean,
that.
no. I mean, if there's if you have an active fissure, hemorrhoid that's actively bleeding, we're going to avoid internal work at that point. But no, it's very safe and conservative. That's one of the nice things about physical therapy, is it's very safe. Not to say that we can't flare up symptoms temporarily if we're trying to push a little too much. But as far as, there's really no contraindications.
Right. And which is also the difference between the guys trying to do it on their own by buying something online, where they can potentially do some pretty bad
Yeah.
damage. I'll put you on the spot a little bit. You put benchmarks to your treatments. And so that makes it you, not only the patient, but you yourself, be able to evaluate success. To what
Mhm.
extent do you see success? If you had to quote, like, doctors you go to a surgeon and say, my success rate with this is X%. Could you put it in that parameter? Or how would you define success? And how successful would you
Yeah.
think you are in terms of treating pelvic pain?
Um, General statement, we're quite successful. Now, we do not keep statistics. We don't keep
Sure.
that data. So I really can't say very confidently. The majority of our patients absolutely see success. Are all of them pain-free? No, I wouldn't say that necessarily,
Sure.
but have the majority of them reached their functional goals, like getting back to, whatever their desired sexual functioning is, or their desired exercise plan, or being able to go back to work, take care of their kids? Yes, I would say the majority of them, absolutely.
Yeah, and absolutely, like I said, it's a continuum, and at least you're setting the benchmarks and the goals. It's easy for them to evaluate, but it's also good to know that for the majority of patients, you're making an impact, which is important. Now,
Absolutely.
last group of questions is, as we started the podcast, a lot of doctors don't even know who to refer patients to. First question in this segment is, how can someone find someone like you
Mhm.
to help them? How can they find a physical therapist who specializes in pelvic pain?
Yeah, it's a great question. There are a few directories out there by different organizations. The American Physical Therapy Association has a directory. Unfortunately, it's considered women's health, but there are also providers there listed that treat men. Herman and Wallace is an organization that is a continuing education organization, but they also have a directory that lists providers. And in these directories, often physical therapists will list who they treat. If they treat men and women, maybe certain specialties that they treat, maybe like pudendal neuralgia, or if they treat something like pediatrics. However, if you find someone in your area with one of these directories, for men in particular, it's a good idea to call and ask if that particular physical therapist has experience treating male pelvic pain, because it is different treating men and women. It is also different treating a man post-prostatectomy, or when they have their prostate removed, versus treating men with pain. It's a very different treatment approach. So I always recommend that men ask specific questions. Does this physical therapist commonly, not just once a year or something like that, commonly treat men with pelvic pain?
And let's say, and that was going to be my next question, but let's say they say, yes, they do. Dr. Jones absolutely sees men with pelvic pain. When you're seeing that physical therapist, when you made the appointment, are there additional questions in that initial consultation that you as the patient should be asking to gauge the true competence of that practitioner that can make you feel more comfortable? Or maybe there aren't, I don't know.
Yeah, it's a hard question to answer, but I would say if that physical therapist is doing a comprehensive assessment, meaning they're examining tissues and from externally as well as an internal exam. If you see a physical therapist that does not include an internal exam as part of their assessment, then they likely are not the therapist for you.
Yeah, that's a good piece of advice. Thank you so much. This has been fantastic, and I know I learned a ton. Before we let you go, we're going to ask you a question that we ask of all of our specialists, because you're not only an expert physical therapist, you're also a very successful person, and part of our podcast is overall success and wellness. So the question I ask you is, how do you live your best life?
Wow, I wasn't prepared for this question.
That's
How do I
always a
live my best
curveball.
life? Yeah. This sounds so, I don't know, of today, but I think, and I will draw from my younger colleagues that I think have been teaching me this, is trying to have better work-life balance. I think younger generations have made that more of a priority, and I think that's an important lesson to learn from them. Especially as a business owner, you can get really caught up in work constantly. So I think taking the time to, really enjoy other things and pursue other hobbies. I enjoy being in the mountains, and I have 2 shepherds that my partner and I like to take in the mountains and do everything we can outside when we get a chance. So luckily in New Hampshire, we have lots of mountains at our back door. So yeah, that's how that and cooking. I'm definitely someone who lives to eat, not eats to live. So yeah, in the kitchen or on the mountain.
That's fantastic. Well, I think that's great advice, and I think that they're onto something with this work-life balance. Elizabeth Akincilar, thank you so much for joining Better Man Clinics, and to everyone out there, thank you for joining. Remember our philosophy here that your best life is a journey and not a destination, and use every day to get just a little bit better. If you like this conversation, please give us a 5-star rating, and we will see you next time. Take care.